everybody. Thanks for coming today. It's a pleasure to see a bunch of people that are interested in the same things that I am and with whom I don't have to prove that this is important. So that's great. I'm Dr. Vanderkalk, and I work in Michigan at the Western Michigan University Homer Stryker MD School of Medicine, and I'm the program director for one of our two family medicine programs there. I do not have any financial disclosures today, and just some objectives for kind of what we're going to talk about today is really discussing how we can go about getting gender affirming healthcare a part of a primary care residency clinic when you have a lot of learners, a lot of faculty, a lot of people who have to be on board in order to do that. For a little bit of background, the most frequently cited barrier by program directors in family medicine to actually teaching gender affirming care is both the lack of transgender and gender diverse patients, as well as lack of faculty expertise. So those are the two things that we hear from, at the very least, family medicine program directors, which I think probably extrapolates to other populations as well, as to why they are unable to teach gender affirming healthcare to the residents within their program. Just a little bit of background on our story. So I started doing some transgender and gender diverse care about 10 years ago in Kalamazoo. At the time, I was a part of the faculty for the residency program, but was not program director and was just sort of doing this on my own as a single individual physician. I think probably many of you have ended up in similar situations or scenarios to that, where you're sort of the person at your institution or in your program who's doing this type of care. And so then what happens with that moving forward if you, as that single only person, are moving into other parts of administrative duties or whatnot? So in my case, I started doing this, and a lot of residents expressed interest in joining me and learning about this. And at the same time, the gender affirming care or the gender diverse population within Kalamazoo found out or figured out what I was doing. And so all of a sudden there were a lot of patients, and then quickly that outgrew my ability to care for those patients individually. And so what eventually ended up happening was a dissolution, more or less, of my quote unquote transgender care clinic into having gender affirming healthcare be a part of just the regular care that we provide to all patients all the time. And that was a long process, and one that came with plenty of struggles. And so we'll talk about what those were today and kind of identifying them ahead of time, trying to prevent some of the pitfalls that I ran into, and then also some of the QI stuff that we're doing in our institution right now. So I think the first big piece that everybody thinks about is dissemination of knowledge. And I think that when we're thinking about those things, we have to think about a number of different aspects of that, including not only who needs to have the knowledge, but what knowledge do they need, and how are you going to get that to them, and when are you going to get that to them? Are you going to do that before or after they're seeing these patients? All of those sorts of things. I think obviously the who includes your faculty, preceptors, and residents, right? So these are the people who are actually providing care to the patients that are coming through your clinic. These are the people who are precepting the resident physicians who are providing care. And so it's really important that you disseminate some knowledge to them about how to go about doing this. And I think it's really important that you don't forget about the other people. So as you all know, our patients have to go through lots and lots of people to actually get into an examination room. And this looks different in all different clinical scenarios, whether or not you have, a phone triage team, if the phone persons are directly in your office, what kind of staff you're working with, what your front desk staff, is this specific to your clinic or to a bunch of clinics? et cetera, et cetera. But thinking ahead of time about who these people are that your patients are going to come into contact with before they get to you is an important piece of having a lot of trans patients then coming through your office. Um, this definitely was an issue when I first started doing gender affirming care, in that the front desk staff didn't have any education on this whatsoever. And by virtue of the scenario that I was in, I was not able to disseminate information to them either. And so this became just a part of caring for the patients within that institution. Was, I'm sorry that you have to go through all of this BS to get to me, and we're going to do our best to provide gender affirming care to you now that you're here. I think the what is also something that's worth thinking about. As prescribers, we're all aware that initiating hormone therapy is probably a little bit different than just continuing hormone therapy. The complexities of those things are different. The laboratory evaluation and frequency of lab evaluation is probably different. And there are nuances to initiation of therapy that that pop up, that don't pop up during continuation of therapy as well, such as when are you going to start and what kinds of things are you going to require for people who are initiating? Are you going to use a mental health gatekeeping model? Are you not? What are people comfortable with doing within your institution, et cetera, et cetera. And so thinking about what information you want to start with for people, just from the basics of initiation versus continuation, I think is a great start. I think lab monitoring is important as well. And talking with people about how often is it appropriate to be getting these levels? Do we need to get baseline levels? What reference ranges or reference intervals are we going to be using once we have patients on these hormones? How often are we going to get those, et cetera? Is there a protocol that you can develop for this within your office, or a point of care resource that you just want to utilize, like the USCSF trans guidelines, for instance, and just encourage people to follow those? So lots of different things to think about with that as well. Meds and dosing, I think, is the next part. Surprising, it was sort of surprising to me how this became an issue, actually. So obviously, there's lots of formulations of the medications that we use. All of you have probably used these with cis individuals, in addition to trans and gender diverse individuals. And somehow or another, it turns out that none of my residents know how to prescribe needles and syringes. And so this was actually the biggest thing, is what size syringe do I use? What size needle do I give them? How long is it? What gauge is it? This was a huge piece of education for, at the very least, our resident physicians, if not also the faculty physicians. So something to think about there. And again, lots of different references exist, point of care resources for this. And I would encourage you to utilize those as opposed to making your own stuff up. But I think it is an important piece of the educational aspect for people. I think it's also worth thinking about, as we talk about medications here as well, is, are you going to use things like bicalutamide? Are you going to use progestogens? What ones are we going to use? Are you going to use spironolactone versus eplerenone, and why? And I think there's so many things that come up, again, so many nuances in this care that come up, that I think it's worthwhile speaking about some of those things from the front side. I also live in Michigan, which is the home of Dr. Benjamin Powers. And so I hear a lot about bicalutamide from all of my patients who go to his website. And so talking about that upfront has been important for providing care within the state of Michigan as well. I think the other piece is discussing with your learners what kinds of expectations they should share with their patients about the care that they're receiving. It never ceases to surprise me that the residents think things like, we're going to be able to make your shoulders narrower or your hips wider, or we're going to be able to make your the pitch of your voice higher again, those sorts of things, and having to just continuously revisit these expectations with them and what kinds of changes our medications can make and which kinds of changes our medications cannot do anything about. So continuing to discuss those. I'm not sure if any of you are familiar with Rainbow Ontario, but they have some really great visual aids for some of these changes and timelines for changes as well. And then other things that are going to come up with patients and when you're providing patient care, which includes some of the practices of binding, tucking, packing, but also where can I go to get laser hair removal, or what kind of hair removal is best for me? Are any of the places in town gender affirming? What kinds of surgeries are available? Where do I go if I want information about surgery? Where can we refer people to for surgery? So all of those things. I'm sure that there are other things too. If any of you want to toss out anything else that has occurred to you during the last few minutes, please feel free. So the question was whether or not I have a standard curriculum for all 3 years of the residency. And the answer to that is sort of, but no. So we will talk a little bit about, I do have a standard curriculum that I provide to all of our interns when they first come into the program, to sort of at least get them a little bit of baseline knowledge, and then continue to integrate gender affirming healthcare into regular didactics throughout the course of the 3 years that our residents are with us. But there isn't anything specific that I'm providing to PGY 2s or 3s as compared with the PGY 1s.
Hi. Oh,
Yeah, please.
do you, by year of training, adjust the patient flow in any way, or take that into consideration for patients? Yes, mostly.
In specific to transgender and
Yeah, mostly probably initiating. So
Yeah.
a new patient evaluation and seeking their first foray into maybe hormones, gender affirming hormones, which seems to be one of the more challenging clinical situations for learners and even faculty that are coming on board.
No, we are not sophisticated enough with our scheduling, I don't think, to be able to manage making sure that we're getting only initiations on PGY 2s or 3s. So anyone who has a concern about care for gender affirmation purposes is welcome in any of the slots in our clinic at this point. So then when, where, and how, and I kind of combined all of these together. All of you are coming from programs that are different. We all know if you've seen a program, you've seen a program. And so there's lots of different things that are going to be specific to your scenarios that are worth taking into consideration. But are you going to try and provide this education to people synchronously or asynchronously? Is this something that they can just review on their own online? Or is this something that you want to have a didactic session for? Are you going to do a didactic session? Are you going to do a case-based kind of session? Are you going to do just a PowerPoint, here's the rules kind of session? Are you going to just teach them on the fly in clinic when they're seeing these patients? Or is it a mixture of all of these things? Does some of the information have to happen before they start seeing patients, and some of the information can happen concurrently? I think there's a lot of questions there that need to be answered when you're thinking about how to get this knowledge to your learners as well as your faculty. And maybe this information looks different when it's going to faculty than when it's going to your residents as well. And the timing of that has to be different. In our particular example, I did provide the information to faculty before I started disseminating the information as in a very structured format to the residents. And we did this during one of our faculty meetings, quote unquote retreats, which in our institution just mean really long meetings. And yeah, just a mandatory 4-hour meeting. So this is where I first introduced the information to our faculty, and it's obvious and evident as well that ongoing education for our faculty is going to be important too. So any other thoughts about who, what, when, where, how that people have or want to share?
The timing of the lecture and the time that the learner has their first patient presenting with it is challenging.
Yes.
So I imagine, an in-person training and then really clear information about where to find the information in an asynchronous manner when they need it point of care. And then having tip sheets that are really, because you can have a 30, 40 slide deck PowerPoint and they're like, what is the starting dose of estradiol? And they just need a tip sheet. So also kind of distilling the information. It's challenging because it takes a lot of time to do this and keep it updated.
Yes.
So I guess that was more commentary rather than a question. And
That's great. And that is actually part of our ongoing quality improvement right now, is creating said cheat sheets in order to have that information even more readily available than Googling UCSF trans guidelines.
Do you use OSCEs or standardized patients with the first and second years? Because we sometimes have with like a parent coming in with their child, or so it's been really helpful for them to sort of get used to those types of scenarios and feel
Sure.
comfortable.
We have not to date, but great idea, I think, using standardized patients. And also in the past, when I have done things with standardized patients in our institution, we've had cis persons that are dressed in drag or something, I don't know, as the standardized patient, which I don't think is a great way to teach people how to interact with the trans and gender diverse community. So
we started using digitized storytelling if we couldn't get live, and I'm presenting on Wednesday about that.
okay.
But it's been really, really helpful
Great.
to do that. Yeah.
Great. That sounds like a great presentation, which I will miss, but I'm going to listen to later. So thank you for letting me know about it. All right. So just moving into some of the pitfalls that I encountered in starting this program within our residency. I think this will come as no surprise to anyone that morals, values, ethics all sort of popped up in this. And that has included not only faculty and residents, but also staff persons who either don't agree with gender affirming healthcare in general, or think that it's child abuse, or that religiously they don't feel that they're able to initiate hormone therapy for anyone, but maybe they are comfortable continuing hormone therapy for people. Maybe they don't want to do either. And so those nuances have come up often. And I have at this time really sort of tried to navigate those things on an individual basis. And I will say we do have a couple of residents who do not see any gender affirming healthcare patients as part of their patient panel. And we do have one faculty person who does not precept initiation of hormone therapy. So those sorts of things have come up over time with new faculty joining, with obviously new residents every year. And I think that for me, trying to approach the morals and ethics and kind of forcing people to do this doesn't make a ton of sense. And so, yes, our residents all learn about gender affirming healthcare, and not all of them do it. The electronic medical record, yeah, sure.
I had some success at a program with not just around gender affirming care, but our issue was circumcisions and the call pool. And I mean,
Yes.
obviously reproductive health care is a big
Yes.
issue. So we initiated in our interns a session during orientation about sort of let's explore our values and morals. And it was a much more transparent, open way to let people explore that and give some information as well to the program so we could start addressing that preemptively, proactively.
That's a great idea. Yeah.
in thinking about the whole clinic, how you really have to have buy-in from the whole clinic. In our clinic, as we were transitioning to being more inclusive, we started having every 2 years, we have sort of an education discussion with everybody in the clinic. So it's not just the interns, it's not just the residents, but it's the front desk, it's the call center people, it's the MAs, it's the nurses, and sort of it being more discussion based so people can really, and sort of small table based, so people can really sort of talk through how they're feeling a little more honestly, and then sort of work through how they are gonna, rectify what their feelings are when that patient comes into clinic and they have to room that patient. And so I feel like that was helpful. An example that we often came up was if someone says, well, my religion says this is not part of my religion, blah, 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 blah. I don't believe in this. Okay. I bet your religion also says not to have premarital sex. But when we have a 14-year-old who's pregnant, you have no problem coming in and rooming that patient and taking care of that patient. So like clearly you know how to take care of people. So why is this your line? And then sort of helping people sort of understand where their lines are for everybody in the clinic.
That's cool. So electronic medical record, we all use different ones. You can turn things on and off and add them and not use them and use it. And it's way beyond me, this IT stuff. And also it is important when you are working with transgender and gender diverse patients to have a way to document what name they use and what pronouns they use. And thinking about whether or not your EMR is going to auto-populate pronouns into your physical exam, for instance, without you even knowing, and what pronoun does it use? In our case, that is the quote unquote administrative sex that gets put into the note. And so regardless of what pronouns the patient has indicated that they use, it just is based off of the administrative sex. So lots of nuances again to that, and to how the paperwork prints out at the end of the visit or on the My Chart or electronic access to the patient, and things to think and talk about with patients as well, to say, this is how this is going to show up, and this is how the system is designed, and I'm sorry it was designed that way, and here's a heads up about what this is going to look like. And also just orienting people to where is the SOGI information within your electronic medical record, and how can it be updated from the clinician side is important as well. So PTO, this came up really a lot earlier in the process for me than what it came up then, as opposed to later in the process where some of these other things came up. But what happens if I'm gone? What happens if I'm at a conference about trans care and I can't answer your question about the gender affirming care of the patient in front of you right now? What happens if I'm an inpatient and super busy? All of us have different portions of our job that pull us away from being able to answer direct questions about patient care. And so thinking about who or how many people need to be involved, especially early when you're sort of the champion, is there someone who can back you up when you're gone? Is there someone who's willing to do that? Is there kind of a second champion that you can pull on board with you early in the process? Kids and adolescents is another thing that has come up recently, is basically how low will you go? So are you going to do pubertal blockers? If you are, is the whole faculty on board with that? Or is the whole faculty not on board with that? Are you willing to treat adolescents who are Tanner stage 2 or 3 or 4? Only, where is that cutoff going to be? And I will say we are in the midst of those conversations with our group right now. And there's lots of nuances again to this. And so another thing that has to be thought about, how has this been communicated with the referrals department as well? Do they know what your cutoff is for providing this sort of care? And is it something that can be told to the referrals department in terms of, it's a specific age, or is it based on Tanner stage, and how do they get that information? So lots of different things there. And then, as I talked about before, that this comfort with knowledge and confidence with titration and point of care resources and all of those things has to be ongoing education in order to keep people sort of in an area where they think, okay, yep, I know sort of what I'm doing and I feel confident and comfortable doing this. Any other pitfalls that people want to share?
The,
Mm-hmm. Yeah. Yes. So the question is, what resources am I using to actually do the education of the faculty and the residents? What guidelines are we following? And I will say that we use UCSF because that's what I find the easiest to use, and therefore that's what I tell everyone about and how to get to. And I also am in favor of some of the other guideline systems out there. I mean, WPATH is obviously a great resource as well, but keeping it really simple, I think, more than anything else. And so that's the point of care resource that all of my residents and all of our faculty are aware of, and therefore what we generally use. Good. Okay. So then just a couple things in terms of continuous improvement, and we've talked about a bit of this already, but just really talking about with faculty what the comfort level is of everybody in doing this, having open communication in a non-judgmental format, and really just being able to listen and hear what people are thinking and feeling about providing this sort of care. That is something that has taken place within our faculty a number of times and continues to take place regularly at some of our faculty meetings, even if it's only 5 or 10 minutes at a time. But I think it's really important, as Marie was saying earlier, like we need to be able to have conversations with people about what kinds of feelings are coming up, what kinds of lines are being drawn, why are those lines being drawn, and thinking about that together, and respecting the lines that other people have drawn as well. As I mentioned before as well, in response to Vern's question, we are in the process of developing sort of one-pager cheat sheets, and this will be based off of UCSF guidelines, but we'll include some of the stuff that I presented at the beginning in terms of like who, what, when, where, mostly who and what, so that residents and faculty members can just really easily get to that information. And then also, as I said, we are doing part of intern orientation is kind of the basics of gender affirming care. So at least getting our PGY1s in a place where they can have respectful conversations with trans and gender diverse individuals before they get thrown to the wolves. And then ongoing didactics education, integration into other aspects of care so that transgender isn't just this thing that's kind of all sequestered to itself. And so how do we talk about that when we're talking about anemia, for instance, and how do we include some of this in a lot of the topics that we talk about with our residents and didactics on a regular basis. So that is kind of what I have for you all. I'd love to hear what other people are doing or hear any other questions that people have. And this is my email address, which is probably not what's published in whatever stuff is available with the conference information, as we just updated our email address for fun. I'm really pleased by it.
Have information about how to build your when you were looking up information about how to build more than just you, right? So that's where I'm at, right? More than just me.
Yeah.
Because I had some time off from my oldest kiddo who had actual top surgery. So it was really great. But I took 3 weeks off. And in that time, the things people reached out to me for, a lot of it was mental health and a lot was gender affirming care. And it really kind of impacted me, your PTO point, where I was like, I really want this to be more broad.
Yes.
So if I'm looking for more than me, right? Did you use resources from like med ed portal, or where did you find like the material? Like that curriculum structure where you're like, God, I gotta have a formal something.
Yeah.
Do you have any tips that way?
Yeah, so very little exists in the realm of transgender and gender diverse education within family medicine for sure, within medical education in general. I've actually done a couple of studies specifically with family physicians on, are people learning about gender affirming care? Are they teaching about it? How are they doing it? And the numbers are not great. There's a lot of people who feel comfortable using they, them pronouns, and then that's like basically the end of their transgender education. And so I think for me, I was doing a lot of education already with residents that wanted to rotate with me and or follow me in my clinic. And so that kind of just started organically. And then I also just created materials on my own to share with people. And if you reach out, I'm happy to share some of that stuff with you. I think that Gap Crack is also something that is up and coming, and that sort of started organically from a group of educators that were all at WPATH, and they're looking really, correct me if I'm wrong, to have a pool of those sorts of resources that are available for free for people to utilize in their own situations. It's not there.
Share Erica Sullivan would probably be the connection. So Gap Crack, I can't even remember what it stands for. Gender affirming something. Yeah, it's just been invented, but you're affirming our suspicion that having this bank of educational resources for folks will really help them. Yes, no, we want to disseminate our work. So it's not stealing, it's actually affirming people in academic positions and their need to disseminate their work. And so, yeah, I will see, let's connect so we can get you kind of started, but ultimately it will be, it'll have a website, but it's not ready yet.
Oh, yeah.
I think Erica Sullivan said that she was at some point during this conference gonna kind of introduce it and have a QR code that you can scan to sort of join the masses. And again, the goal. Yeah. Yes, that's it. That's it. Yeah, that's exactly it. Yeah. Yeah. Right. So we know that everybody is sort of on their own, working in silos, creating these curriculums. So what if we didn't all have to reinvent the wheel each time? What if you're like, I want to do this, but I can't take it all on myself? Where are, of course, like you said, each program, you see one program, you're going to need to make it your own, but how do you even start? So that way we can at least start.
All right, thank you so much. I think it's we're going to transition into the next presentation. I hate to cut this really rich conversation short, but feel free to keep asking questions and connect with the presenter afterwards. Thank you. Join me in thanking them. Thank you.